Okay, it's 11 a.m., so I'm going to go ahead and get started. Hello, everybody. I'm Dr. Uzma Samadani, and welcome to our webinar on long COVID and the effects on the brain. I'm the CEO of Oculogica, which is hosting this webinar. And Oculogica has developed the first aid and diagnosis of concussion that is authorized by the FDA. Very excited to have everybody here. You can go ahead, Laura, to the next slide. We've got three wonderful speakers with us today. Dr. Alice Perlowski, Chief Medical Officer of Blooming Magnolia and a board-certified cardiologist, and actually a long COVID patient herself. She will be speaking on the patient perspective. We also have Dr. Uzma Samadani. She is a neurosurgeon at the Minneapolis VA, an associate professor at the University of Minnesota, and she will be speaking about neurodiagnostics in this area. And then we also have Dr. Avindra Nath. He is the clinical director of the Translational Neuroscience Center at the NINDS at the NIH. And he will be speaking about long COVID research and where we go next. We know that a lot of press has been out there, even very recently, about long COVID. There was something in CNN on September 29th about more people suffering from long COVID than we had expected. And just so we've got a little bit of a sense of who is in the audience, we're going to ask you two quick questions. You will see a poll pop up. And obviously, everything is confidential here. We're not going to be able to tie this back to you. But just a quick sense of how many of you have had COVID-19, a positive diagnosis of it, and asymptomatic, symptomatic, whatever. So if you could just select one of the following. And as soon as we've got, I know people are still joining, but as soon as we've got a majority of people. Okay, so we've got 59% yes and 41% no. So the majority of you have had COVID. And then a second question regarding your symptoms and how long they lasted. So we'll put up that second poll now. And for only those of you that said that you had COVID, did you have lingering symptoms beyond 2 months? And if you're just joining, you didn't get a chance to answer that first question and you had COVID, feel free to answer this question. So we're just wondering, okay. And we've got 90% said yes and 10% said no, which is probably a little bit of an overrepresentation. I'm going to hand it over to Dr. Alice Perlowski now. Thank you so much, everybody.
Okay, thank you so much. It's an honor to be part of this panel. So my name is Dr. Alice Perlowski. I am a physician, but I'm going to be putting on my patient hat today and talking about the neurological effects of COVID-19 from a patient perspective. A lot of people think that there are only 3 outcomes when you get COVID. You recover, you're hospitalized and you recover, or you die. And I hope by the end of this presentation, you see that there's a 4th pathway. And those are the millions of people around the globe who are still suffering from symptoms from COVID. So I was a 43-year-old full-time cardiologist, extremely healthy. I was a marathon runner. I had run over 50 marathons before I got sick, including 8 Bostons. No history of migraines, head trauma, neuropsychiatric issues, and no other comorbidities. On March 6, 2020, I developed a red right eye. I also had a low-grade fever, shortness of breath, diarrhea, and loss of taste and smell. At the time, I didn't qualify for a COVID-19 test because it was very early in the pandemic here in the US. In the first week, I had worsening shortness of breath, inability to eat, severe diarrhea, and I actually became cyanotic. You can see on the right panel, my nail beds were blue, and so are my lips at the time. I then became very confused. I got paranoid delusions and hallucinations during the second week. And in the third week, I actually started coughing up blood. I was having episodes during sleep where I was stopping breathing, and I was essentially delirious. On my first presentation to the hospital, I was admitted for hypoxia with an oxygen saturation of 82%. Interestingly, my chest x-ray and regular chest CT were unremarkable, and my SARS-CoV-2 test was negative, but it was thought that maybe I was outside the testing window. A few days after I came home from the hospital, I was found unconscious in my apartment by my mother. She had tried to call me for 8 hours and did not get a response. I declined to get medical attention at that time. Over the next several months, I continued to be short of breath, hypoxic. I was confused, weak. I developed neurological symptoms, including left hand and foot numbness and weakness. And I also developed severe personality changes. So I purchased a guitar, and I don't play guitar. And I also was posting things on social media like this, where I was dressed up in a wig, looking like a hippie, and that's not typically something I would have done before this. I was hospitalized again in May 2020 for hypoxia, again had normal chest imaging, but I was tachycardic just at rest, normal echocardiogram, and I was discharged with a plan for an exercise test. At this point, I became scared for my life, and I prescribed myself oxygen for home. And I actually started to improve with the oxygen. In August 2020, now this is several months after presentation, my PCP detected word finding issues during a televisit, and she was concerned I was still unable to read, write, or speak fluently, and I certainly wasn't able to work. On neurology consultation, I had an abnormal cognitive assessment, and my first MRI showed multiple white matter hyperintensities, as you can see here. I was worked up at the Mayo Clinic at the end of 2020, where I had other head imaging. My 3 Tesla MRI showed 28 scattered white matter lesions with enhancement of a lesion in the left posterior frontal lobe, which was thought to be subacute. So essentially, they thought that this was something that had occurred since the respiratory illness, which was likely COVID or was COVID. And I also had diffuse microhemorrhages. My lumbar puncture just showed elevated protein and no evidence of multiple sclerosis. My health continued to decline over the months of 2020. I developed acute appendicitis 8 months after original presentation, requiring an emergency appendectomy. And then in January 2021, I developed gallbladder inflammation and had to have the gallbladder out as well. And you can see all the scars from these surgeries. So I had multiple organ involvement, including thyroid, liver, gut, and this was thought likely to be due to microvascular inflammation and microthrombotic events, which likely were the cause of the brain issues as well. So I'm now 19 months out. I'm doing much better, but I am left with short-term memory deficits. I have to write everything down. I have deficiencies in executive functioning, reduced word recall, severe fatigue. I have migraines now, light and sound sensitivities, upper and lower extremity neuropathies, and I actually developed a superior laryngeal neuropathy. The superior laryngeal nerve is a branch of the vagus, and I've had to get several nerve blocks for this. My most troublesome residual symptom is dysautonomia, or postural orthostatic tachycardia syndrome. So my sitting and laying heart rates are in the 60s, and when I stand up, they shoot up into the hundreds. And this is pretty much definitive for POTS. I also have developed fluctuating blood pressures, which I've never had before. But I'm actually lucky because there are a lot of people out there that have very troublesome symptoms, such as macrovascular strokes that have left them disabled, seizures, internal tremors, loss of vision, inability to drive. The list just goes on. So my final diagnosis was encephalopathy in the setting of COVID infection, complicated by prolonged hypoxia, which is being treated like a traumatic brain injury. I just put my treatment plan up here just to emphasize the majority of these treatments, which are not cures, are all out of pocket. They are not covered by insurance. And there are a lot of people experiencing financial insecurity now due to their inability to work. And you can imagine it's very difficult for them to be purchasing all these meds out of pocket. The impact for me, I spent a year not able to work, but I've been working part-time since March 2021. I am still unable to stand for prolonged periods of time. I can't remember about 11 months of detail of my life. And of course, the PTSD and trauma that comes along with being a healthy person to everything that came with being hospitalized and being so sick. And I think if you ask anyone who's been through this what the most traumatic thing was, it was probably convincing people that this was actually real, that this was something that was going on in their bodies and not something that was a figment of their imagination or psychiatric problem. So I head the COVID Brain Club on Facebook, which is a support group for people who have neuropsychiatric issues from COVID-19. And I polled them and I asked them, complete the sentence, the neurological effects of COVID, and here are some of the responses, have been affecting my daily life for the past 18 months, should be recognized as a disease and not as a psychological state, are ruining so many people's lives, lead the mind and body on a vicious cycle of unpredictable symptoms and sequelae, can be life-changing not only for the survivor, but for their families and caretakers, can render even the most intelligent of us in a puddle of tears and frustration, are frightening, affect children also, and can happen to anyone. So that gives a really good perspective of how troublesome this is. So I just want to remind all the COVID survivors out there, something Michelle Obama said, that every scar that you have is a reminder, not just that you got hurt, but that you survived. You can find me on all these social media platforms, and I am the Chief Medical Officer of Blooming Magnolia. You can find us at bloomingmagnolia.org, and we're trying to provide emotional and financial support for people suffering from post-COVID sequelae, and also hopefully try to fund some of the research efforts to try to find cures. Thank you so much for your attention.
Dr. Perlowski, thank you so much. You really, when I first heard your story, it really brought to life what this is like for some people. We're now going to have Dr. Avindra Nath present.
Okay, that was a very moving presentation. Thanks very much. And it flows really well into what I have to say about COVID. And so I wanted to start with this quote from Sir William Osler. He was the chair of internal medicine at the time, and he gave a keynote address to the American Medical Association in 1896. And he said, humanity has but three great enemies: fever, famine, and war. If he gave that same talk today, he would probably call it climate change. Of these, by far the greatest and by far the most terrible is fever. And that is true because infections have really shaped this planet and humanity. They kill more people than anything else on this planet. And in fact, our own evolution has occurred because of waves of infections that come and wipe out huge populations on the planet, and then few remain and they repopulate, and so on and so forth. And these pandemics also have huge social consequences. And some of us will remember the AIDS pandemic when it did occur. I mean, it's still ongoing, but in the 80s, there was a lot of social unrest at that time. And people doubted science as well as and the silence that came with it. In front of the Capitol building here, each year there used to be the AIDS quilt, and each piece of fabric represented an individual who had died of AIDS. Ultimately, the quilt became so big that it couldn't be accommodated on the mall any longer. 35 years later, this is at the time of inauguration of a current president. Same mall, this time we have flags there. There are 440,000 flags at the time when he was inaugurated. Today, there are already 700,000 deaths that have occurred. Okay. So, and we think that that's an underestimation, and the real numbers are probably closer to 1 million people have died just in the United States alone. And still, they are close to 2,000 deaths a day. If you look at these coronaviruses, all coronaviruses are known to cause neurological complications, but it really does not get recognized till much later in the pandemic. That unfortunately is the case with most infectious agents. People get focused on the primary organ that gets involved and do not think about the brain. But ultimately, it is the effects on the brain that really cause the long-term consequences of the illness. So I'm going to talk a little bit about the neurological complications from COVID-19. I wanted to start with this letter that I received from a husband of one of the patients. And in this letter, in this email that he sent me, he says that it is with deepest sadness that I must let you know my wife took her own life Saturday after battling long COVID for over a year. The unrelenting neurological pain mixed with other painful symptoms that made sleeping virtually impossible became too much for her to bear. She wants the world to know how real long COVID is and how it can take everything from a person. And before COVID, she was a totally happy mother, wife, and person who loved life. So this, unfortunately, is a rare instance, but yet it brings to light how terrible these neurological complications can be. If you look at the types of complications, you can divide them into two. First is what we call para-infectious. Those are ones that occur during the acute phase of the illness and can affect the entire nerve axis. This inverted triangle represents the complications that occur most commonly on top and the least common at the bottom. A number of post-viral syndromes that can occur. These are all immune-mediated, but can involve the entire nerve axis, and I'll discuss some of them. First, I want to talk about vascular injury, just as Dr. Perlowski mentioned that there was a fair bit of microvascular injury that she had experienced. There are many different types of vascular injuries that have been reported in patients with COVID. So this is a CT scan from an individual who has a stroke, and you can see all this area on both sides of the brain. There are these huge strokes that have occurred. This one in the middle has all these black dots represent small hemorrhages. So this patient individual had multiple hemorrhages. And then this one on the right shows an occlusion of one of the venous sinuses in the brain. So you can get any of these different types of manifestations or combination thereof. And what causes strokes? One of the possibilities are these antibodies, and they're called antiphospholipid antibodies. So this is a group from University of Michigan. They found these antibodies in nearly half of the individuals who were admitted to the hospital with COVID. And they also found that these antibodies were pathogenic because they took them and they gave them to mice, and the mice developed clots as well. We looked at autopsy brain tissue from patients who had died of COVID, and we stained it for a protein called fibrinogen. This should be present in the blood and not in the brain, but all this brown staining you see represents fibrinogen leaking into the brain. This is a small blood vessel, and around it's really dark, and again, most of these blood vessels you see really dark staining. So I'm going to suggest that all the leakage is coming from the blood vessel and then diffusing into the brain. Looked at the blood vessels more closely, and in some individuals we found that all these small cells here are platelets, and so they're brown in color because they're activated platelets, and these activated platelets form blood clots, and they particularly occlude the small blood vessels. So that's why patients can develop microinfarcts or microhemorrhages. So how does the virus get into the brain? There's a lot of interest about the possibility that could it get in through the nose. Certainly there's a lot of infection within the nasal mucosa, and the cells that are infected in the nasal mucosa are called the sustencular cells. These are support cells. They're not the nerves in the nose that go into the brain. But if you look at the nasal mucosa under electron microscopy, you'll find all these small viral particles here. These dots are viral particles. So there's copious amounts of virus that comes out of the nose. in an infected individual. So it's very important when you wear a mask to really cover your nose. If the mask is below your nose, you're not really impeding anything coming out of there. So in a rat model where they took a different coronavirus, they put the virus in here, and you can show that it will enter the brain and will go all the way down to the brainstem. That has not been shown with the current coronavirus, but that's the concern, that could that actually happen. When it goes to the brainstem, it can affect all kinds of vital structures, including this nucleus that regulates respiration. So if it does affect respiration, there is a syndrome that's called Ondine's curse, which is a central hypoventilation syndrome. And this is a fairy tale in which Ondine had cursed her husband to develop this inability to breathe if he had ever cheated on her. So essentially what happens to these individuals is they stop breathing when they sleep because they can't remember to breathe, and then they die. So we looked for evidence of injury in the brainstem, and we found that in this pre-Botzinger complex, which is where the respiratory center is, a lot of activated macrophages, and the neurons themselves were atrophic. A number of the individuals that we had studied were individuals who had died suddenly in their sleep, and we did find evidence of neural injury in the appropriate areas. What about inflammation? So there are a number of other syndromes that develop in patients with COVID. One is called acute disseminated encephalomyelitis. You can see these enhancing lesions in the brain as well as in the spinal cord, and these are thought to be T-cell mediated. There's another type of lesion that can occur here in the thalamus. This is called acute necrotizing encephalopathy, and this is thought to be cytokine mediated. So the treatment of each one of these would be very different. In children, there can be the syndrome called multisystem inflammatory syndrome. It can also affect the brain here. You can see this lesion here in the splenium of the corpus callosum. And these patients can have multiple organ systems involved and wide variety of neurological complications. So all these children are now going to school are at risk of developing this syndrome. What drives it? We think that and what happens is that the virus somehow exhausts the T cells. This is what is necessary to get rid of the virus, as well as the interferons. And once these are down-regulated, what happens is these macrophages or monocytes get activated. And this is bad news because they are really inefficient in getting rid of the virus, but yet they cause a lot of bystander damage because they produce a lot of oxidative stress, production of cytokines, and this seems to be activated in patients who have neurological complications with COVID. In our autopsy tissues, we also found the same thing around the blood vessels. There are a lot of macrophages here. You can see some astrocytes, but we see very few T cells. If there was a lot of virus in the brain, you would find T cells. We really didn't find it. So we think the vast majority of the complications are really due to compromise of the blood vessels, leakage of proteins here, and then the macrophages are coming in to clean that up, but instead they end up causing damage to the brain. It can also occur in the muscles. You can get inflammation in the muscles here. As you can see, these cells within the muscle itself. But these are all treatable with corticosteroids and if necessary. But there are individuals who develop long-term complications. So this British study shows that if you don't get better by 3 months, like chances are that you will continue to have a number of complications that persist. And it tends to occur more in women compared to men, and the average age is somewhere in the 40s. And this study from the Netherlands suggests that those individuals who are hospitalized, they have greater chances of long-term complications, but it can occur even after mild infection. You can divide these complications into multiple different types. Some that have exercise intolerance, others that have a more brain fog or psychiatric manifestations. Some have autonomic dysfunction, just like POTS that Dr. Perlowski described. And there are still others that have pain syndromes, but there's also overlap between all of them. And this is to show that if you compare individuals who have other types of respiratory infections, all neurological complications are much greater in patients with COVID compared to other respiratory infections. The top line is that of COVID patients, and the bottom one of those with other respiratory complications. And this is what POTS look like. So there's you stand up, as the patient stands up, the heart rate goes up and the blood pressure falls. The blood pressure falls first, and in response to that, the heart rate goes up. And that is because of dysregulation of at the level of the blood vessels. Some patients will also develop ringing in their ears. So about 25% of individuals hospitalized complained of ringing in their ears. And if you did PET scan on patients where you look at the metabolism within the brain, you find that those individuals with COVID had decreased glucose uptake in the cortex of their brains compared to healthy controls. So the brighter colors suggest increased uptake and the darker colors less uptake. So you can see that the cortex is quite different here between the two. So what would you do to treat them? Possibilities are, if you think there's persistent virus, then you need antivirals. If you think there's a dysregulation of the immune system, then you want to suppress the macrophage activation but reverse the T cell exhaustion. So these are potential modes of treatment or that one could consider for clinical trials. Can vaccines cause complications? Yes, vaccines are also been shown to cause a number of neurological type complications that have been associated with it. Some patients can even develop tinnitus from it. However, what is true is that the vaccine works against long COVID too. Unvaccinated people are 4.6 times more likely to get infected, 10 times more likely to get hospitalized, 11 times more likely to die, and 2 times more likely to develop persistent symptoms at 12 weeks. So I'll stop here, and I want to acknowledge a number of pathologists who contributed tissues and helped us interpret the studies. These are people who did all the immunostaining and work in my lab, and the ones that helped us with MRI scanning of the tissues. I'll stop here. Thank you.
Thank you, Dr. Nath, for that very detailed examination of what might be occurring here and what we could be learning in the future regarding long COVID. I'm now going to hand it over to Dr. Uzma Samadani, who's going to be talking about the neurodiagnostics. And if you do have questions for any of our panelists, please feel free to insert them into the chat, and we'll take them at the end.
So first of all, I want to thank very much Dr. Perlowski for sharing her really compelling story, and then also Dr. Nath for talking to us today about the potential reasons for these consequences. And it's a bit eerie for me because I look at his slides, and where he had that picture with long COVID in the middle, you could have had brain injury right in there, because essentially many of the symptoms are very similar. And that's my background, is I come to this from a brain injury background. One thing I will say before I talk about diagnostics is we do recognize that there are indirect neurologic consequences of COVID as well, and it is beyond the scope of our very short time here to talk about those. So obviously the survivor's guilt, the bereavement, depression, issues related to social distancing, collapse of the healthcare system where we're unable to care for other people. And this is really what I've seen firsthand. Healthcare worker moral injury from the difficulties associated with caring for these patients. And then finally, the impact on children. So all of those are beyond the scope of today, but in the future we will discuss them. As Dr. Nath said, it's very apparent that some of this is due to the virus itself, and some of this is happening in the later phases. And so it's important to be able to tailor your diagnostic for the appropriate phase of the illness that you're looking at assessing. This is the incidence of long COVID in the 180 days after COVID-19, based on the medical records of 273,000 survivors as published in PLOS. And you can see that more than 40–50% of patients have some symptom. So this is obviously much more common than we previously anticipated. As we said, up to 1 in 4 post-COVID patients could have symptoms related to chronic fatigue or myalgic encephalitis. And some of the mechanisms underlying this are not understood at all. There's been a speculation that it could be due to the orthostatic hypotension, which is actually a loss of autoregulation. And what that means is that your brain is not able to regulate the amount of blood flow or oxygen that's getting to cells. And in a normal person, you see that. You can see that a normal person, for example, if they run or if they walk, their blood pressure may change, but their brain will control how much oxygen their cells get. The vessels will constrict or dilate as needed. And in someone with brain injury or in someone with long COVID, we see that that mechanism fails. They don't auto-regulate. Other hypotheses, mitochondrial or metabolic, post-inflammatory, as Dr. Nath discussed, microembolic, and then finally cerebral autoregulation. So how do we diagnose these? And that's really what I'm gonna sort of very briefly talk about. The first thing I want to say is that it appears that vaccination helps with at least some of the symptoms, suggesting that residual virus or viral particles may play a role in this. And this is a study that was performed in France. And essentially what you can see is that the unvaccinated patients have a lower rate of complete remission than those who receive the vaccine. What are some of the biomarkers? Some of the biomarkers are largely may be chemical. So this is a graphic from a paper from Journal of Clinical Medicine, basically looking at patients with major depressive disorder and comparing them to patients with COVID. And it looks like many of the biomarkers, or these are called cytokines. So they're signaling molecules that relay information from one cell to another cell inside the body. And those signals change in someone who has COVID, just as they have been known to change in someone who has depression. There are rarer consequences. So one of the things that we see in the neuro field is we see this ascending paralysis called Guillain-Barré syndrome. And this has been reported with an increased incidence in patients who've had COVID. There have been several reports of this. The earliest symptoms still appear to be, as Dr. Nath said, loss of smell and loss of taste. And where those come from are the cranial nerves, right? So the olfactory nerve is your first cranial nerve, and that mediates smell. And then taste is mediated primarily by the 9th cranial nerve, which is glossopharyngeal, and also the facial nerve. And then Dr. Nath also talked about how some of the other cranial nerves may be affected by COVID. So when someone hears tinnitus, for example, that's vestibular cochlear, so that affects hearing. And when someone has abnormal eye movements, those are the optic nerves. So how do we assess function of cranial nerves? Well, one such test is the University of Pennsylvania Smell Identification Test. And this has been incorporated by the NHS in the United Kingdom. And what they see is that patients with olfactory dysfunction have a disruption on this test. What else? How else can you assess cranial nerves? And this is why Oculogica is involved in this, is that we believe that we may potentially be helpful here. We have a test where you watch a video playing on a monitor and we can measure the function of the cranial nerves. So what nerves function can we measure? So there's there's a pupillary reflex that is mediated by cranial nerves 2 and 3. So the amount of light that comes into the cornea and reaches the pupil, and then that is a pathway that feeds back through cranial nerve 2 into the brainstem, and then the pupil constricts, which is mediated by cranial nerve 3, and we can measure that function. And that's something that's been shown to be useful in assessment of brain injury. And then there's also there are also the nerves that move the pupils. So the nerves that move the eyes are cranial nerves 3, 4, and 6. And separate nerves move the eyes in different directions. And if you remember that picture that Dr. Nath just showed, where there were obvious changes in the brainstem due to infection, this is what we are assessing when Oculogica is assessing cranial nerve function. We are assessing not only the nerves themselves, but also how well these nerves are controlled by nuclei in the brainstem. And then finally, we are assessing the pathways that feed into these nerves. So by assessing all 3 levels of function, we can determine whether or not someone has a disruption. And so cranial nerves 3, 4, and 6 move the eyes in a square-like pattern, which is shown here. And then different disruptions in those abilities to move can be measured. So finally, I'll end with this. We have lots of mechanisms for assessing central nervous system function. It is highly unlikely that a single mechanism will be enough to classify the nature of a problem. We have seen this with brain injury, and we are going to see this with long COVID. So what this means is that we're going to be using multiple mechanisms to try and figure out how long COVID or COVID affect the brain. And some of those mechanisms involve understanding what the brain looks like. And those are the ones that are in blue here. So x-rays, angiography, CT scan, MRI scan, those can all tell us what the brain looks like. And we know that after COVID infection, the brain volume decreases, and that's been seen on MRI scan. Some of these other modalities tell us other things about the brain. So EEG tells us about electrical activity. EMG, nerve conduction studies, and SSEPs assess integrity of pathways in the brain. Things like transcranial Doppler and blood flow studies tell us about cerebral autoregulation, right? Because they tell us about blood flow regulation in the brain. Other monitors we don't use very often in people with viral infections, but they have been validated for brain injury. And those are monitors that measure things like intracranial pressure or brain tissue oxygenation. Finally, we have serum markers that inform regarding the chemistry of an injury. We have pupillometry, which only assesses cranial nerve 2 and 3. And then we have our technology, which is on calibrated eye movement tracking. And for that, a patient needs to be able to open their eyes, and we can functionally assess cranial nerves 2 through 7. With that, I think I'm going to end so that we have lots of time for questions, and I will turn the field back over to Dr. Perlowski and Dr. Nath so that they have an opportunity to answer questions as well.
Thank you very much. And to our audience, if you would like to enter any questions into the chat, we'd be happy to take them. But I would like to ask, just start off with asking Dr. Perlowski a question about when you realized your symptoms were going to be long-term, like when you realized it should be over, according to everything that I'm understanding about this disease and everything that I'm hearing, and also when you realized that they were more severe than normal, than typical.
Thank you so much for that question. I think I knew I had pretty severe issues from the very start. In fact, I was preparing my family for the worst. My hypoxia was unrelenting. I think it was probably 2 months in where I really thought that this is going to be with me for a while. I was so hypoxic for so long that I didn't even realize how confused I actually was. Some people say, well, you're a cardiologist. How could you not advocate for yourself in the hospital saying, I'm confused, I'm having stroke symptoms, I can't breathe. But when you're hypoxic and not perfusing your brain, it's very difficult to advocate for yourself no matter what your background. I think I knew that I was going to be in this for the long haul in this summer when the actual brain lesions were discovered. I was initially very surprised. I actually thought that they had looked at the wrong patient's brain scan because I couldn't picture that that would happen to me. But I knew then that I was going to be probably facing this for a while.
Thank you. Thank you very much. Dr. Nath, I am wondering about the possibility of early diagnosis and if there is a possibility of differentiating between long-term and short-term COVID through biomarkers and some of the imaging and other ways of diagnosing. And Uzma, Dr. Uzma Samadani, if you want to chime in on this as well, but I'm eager to hear from Dr. Nath on this, if there is, if that's even a possibility.
Yeah, I think you're absolutely right. We need biomarkers. We don't have good biomarkers at the moment, but there are a lot of ongoing longitudinal cohorts being studied now across the country in a number of academic centers. And one of their major goals really is to develop biomarkers. So these are NIH-funded studies, and they're looking at a variety of immune biomarkers, looking at imaging, looking at serum biomarkers. For example, neurofilament levels is one that they can measure in the blood and quite accurately. That would suggest ongoing neurological damage. Some patients do get spontaneously better. So that those set of individuals serve as good controls, because we can monitor them and see why they get better, others do not. But at the moment, we don't have good, reliable biomarkers, but there's a huge amount of effort being put into developing them.
Okay. And would you like to speak about, and I don't know if you are able to, about the NIH and any efforts that they are encouraging with respect to, that type of research?
So, NIH received $1 billion from Congress to really study post-COVID. And so they have initiated a large number of studies. Currently, there's natural history studies, but it's going to follow. This will be followed with intervention studies. So the call will come out for doing treatment trials as well. So I think there's a lot of reason for optimism. These kinds of diseases, these symptoms, they overlap with what's called chronic fatigue syndrome, and the same issue. People don't believe their symptoms. But it's quite likely that by these studies, not only will we benefit patients with long COVID, but you have all these other syndromes that have been around for a while, and we have not been able to develop good biomarkers or interventions that they all benefit together.
Right. Thank you. And then Uzma, wondering about the value of an early diagnosis. How does that practically help clinicians? So when Dr. Perlowski, realized almost early on, very early on, that she is suffering and it's going to be different. Yeah. What is the value of an objective diagnostic if we can get there?
So I think the first thing is if in order to treat something anywhere in medicine, you have to be able to measure it, right? That's why we are so successful at treating things like heart disease, kidney disease, liver disease, because we have very good markers for it. For heart disease, you can measure, the injection fraction. It's a pump. You know how much goes in, you know how much goes out. So you can assist the pump, right? For kidney disease, it's a filter. You measure protein in the blood, protein in the urine. When you can measure something, you can treat it. And with something like brain injury, a post-viral syndrome, headache, chronic effects of neurotrauma, dementia, these are things that are very, very hard to measure because there's so much heterogeneity of normal function. And so I think what Dr. Nath was suggesting, sort of moving towards measuring brainstem function and measuring things that are relatively conserved across society is probably a better way to do this. So I think serum markers will play a role here. Physiologic measures such as, measures of cranial nerve function are going to play a role here. And so you can measure cranial nerve 1 function with the smell test. You can measure 2 and 3 with pupillometry. You can measure 3, 4, and 6 with, eye movement assessment. You can measure 5 and 7 by looking at blink. You can, or a corneal reflex. You can measure 8 by doing, there's a test where it's almost like a hearing test, but you're essentially measuring brainstem function. And this is a commercially available test for brain injury, but it's specific for hearing. 9 and 10 is a cough or a gag. It's one of the harder, those are 2 of the harder ones to measure. And 9 we know is affected by long COVID. 11 is, shoulder shrug. So then again, there's a lot of heterogeneity in shoulder shrug and head turning. And 12 is tongue. Again, there's some heterogeneity there, probably not as much. So, if we can come up with measures that are objective, then that enables us to admit we have a problem. And then the next step is being able to treat it. We aren't quite there yet when it comes to treatments. But once you can classify the nature of a problem, you should be able to algorithmically develop treatments. That's my hope.
Okay, thank you. I'm going to actually ask if any of you, that our 3 panelists, have questions for each other. It's pretty rare that we get to, have an opportunity to talk like this. So if you have questions for each other, we don't have any questions yet from the audience. So
I have a question for Dr. Samadani. Actually, I'm sure a lot of the patients in the audience are wondering where they can get the testing that you have described. Is it available? Is it something that they need to be referred? And where is it geographically?
Yeah, so eye tracking and cranial nerve testing is available at multiple offices. It's commercially available at offices that already have an eye tracking system in place. So, you know, they can feel free to reach out to me. I'm on Twitter, or they can reach out to Rosina or Laura Shu, who organized this conference, and we can put them in touch with a clinician who has this in their office. Other tests like serum markers, GFAP and UCHL1 are FDA cleared. NFL, I don't believe is, and that's the one that Dr. Nath referenced. Those are a little harder to get. You'd have to be part of an NIH study. If I were a patient with long COVID, one of the things I might consider doing is going to clinicaltrials.gov and looking at who in your area has a long COVID study, because they may have biomarkers that they are assessing. And then Dr. Nath, do you have another answer maybe to that question?
No, I think you're absolutely right. That would be my suggestion too. There are just so many studies and most major academic centers that the best thing the patient can do is to enroll in them. Yeah, and it'll help them, and it will help society and in general. I think we all are alive today because somebody participated in clinical studies, and that's how all treatments and diagnostic tests were developed. And we owe it to society that we participate in studies as well. So that would be my strong encouragement, that it should be done in a proper controlled manner and not just helter-skelter, you know.
We actually do have a lot of questions. Our organizer just pointed out to me where the questions are. So I'm going to start rattling off some of these. One of them is, can you talk about normal brain MRI yet having a lot of neurological issues? Just got diagnosed with functional neurological disorder after 11 months post-COVID. Assuming this diagnosis is from the virus affecting the brain as well as trauma, but also had EBV before COVID. So seems COVID is exacerbated by EBV as well. Any thoughts on all this or recommendations on healing treatments? PT makes this person go backwards and puts legs in pain.
It's hard to give medical advice over the internet.
Exactly, exactly. I think that there's
true that,
just
yes,
in general, you know, sort of like any
one
advice
infection,
for
you get
a
another
person.
one. It's going to 2 and 2 makes 5, doesn't make 2. I mean, doesn't make 4.
Yeah.
So that's to be expected and well established. Yes, I mean, the best thing you can do is you know, follow up with your physicians, let them figure out what the
because there's lots
issues
of questions from patients in here about lack of smell, an increase in heart rate, that type of thing. And so, you know, and then again about tinnitus in COVID, and maybe Dr. Nath, there's a question asking if you can talk a little bit more about tinnitus in COVID.
Yeah.
General, I would say.
So tinnitus is ringing in the ears, and as Dr. Samadani said, you know, there's the 8th cranial nerve, which is supplies the ear, and it supplies 2 parts of the ear. One that controls balance is called the semicircular canals, or the vestibular system, and the other that controls your ability to hear, which is the cochlea. And they're supplied by one small blood vessel. So our hypothesis is that, as I showed you, those blood vessels get occluded. It is quite possible that one small branch that supplies that part of the ear also gets occluded. So oftentimes these patients were complaining of ringing in their ear. If you measure their ability to hear, is actually impaired. So they have both going simultaneously together. One individual I remember treating, he had his tinnitus was so bad the guy couldn't sleep at night. It was usually tinnitus is worse at night because all the other ambient noise is gone, so you hear the ringing in your ear a lot more. Yeah, but it's also associated with anxiety. A lot of these patients have a lot of anxiety that's associated with it. And but for whatever it's worth, in single individual, we treated them with immunotherapies, and he did have some response. However, if you just use hearing aids, the tinnitus will go down. Yeah.
Right.
So the best thing to do is to have yourself evaluated by an ENT physician, or what you call an otolaryngologist, and they can try to sort this out and determine the best mode for treatment.
We've also got a couple of questions about kind of, is there hope here? Are you hearing stories of remarkable neurological improvement, or is this just how it's going to be? And do you anticipate the ability of the brain to heal the lesions, such as Dr. Perlowski was talking about? Any, Dr. Perlowski, I don't know from your community if you've heard of recovery, Dr. Nath, Dr. Uzma Samadani, any hope here for people?
I think I'm living proof that there's hope. I probably 6 or 7 months ago was having trouble reading, speaking fluently. I certainly wouldn't have been able to do a presentation. It would have been really bad. I would not have been able to find words and things. And I've very slowly, now I'm at 19 months, but very slowly have improved. I think that people ask me what I've done. I get as much sleep as I can. I try to do everything possible to let the body heal, and just try to be patient. And I think I have seen a lot of people at least start to slowly improve after the year mark. So I think that there is hope. And I also think when we have brilliant physicians like Dr. Samadani and Dr. Nath on the case, I think we also need to have some hope that people really understand that this is real. This is not some sort of psychiatric imaginary problem. And so I would definitely give people hope. I'm living proof of it.
Yeah. There's a question specifically about GS441524, and that was being evaluated for clinical trial. And if anybody knows the status of that, I don't know if anybody does. No? Okay.
This is the first I've heard of it.
Yeah, there are a lot of very detailed. We have a very educated audience, and so which is fantastic. Wondering about treatments such as gabapentin, B2, melatonin in healing peripheral neuropathy. Where to go for care. There's just a lot of need, clearly.
Rosina, if there's a way for you to collate the questions and maybe we'll review them afterwards, and if people can provide a contact, then we can try and contact them as best we can. Most people, I suspect, are going to be referred to their physicians, because this is going to be something that you have to be under. It's an individualized issue. You have to be under the care of a physician for this, and we're not in a position to dispense medical advice. So I think that that's a challenge here. Speaking very generally, I think that if COVID ends up being anything like brain injury, there's going to be hope for most people, because the vast majority of people who have a brain injury do not develop chronic effects of neurotrauma such that they have permanent neurodegenerative processes. The vast majority do get better. And it's a very, very challenging thing with brain injury. And my suspicion is that it's also going to be challenging with long COVID, but I don't think people should despair, because I think that there are steps being taken to make people be able to find solutions.
Another question interesting about gender differences. So Dr. Nath, you actually showed in your chart the differences, and that the number of women seem to be presenting at higher rates, or rather women seem to be presenting at higher rates, and you gave an age difference. And has there been additional reporting on sex differences in all areas of research? There's a
lot of work that's been done. So all autoimmune disorders, immune disorders are more in women compared to men. Lupus, rheumatoid arthritis, chronic fatigue syndrome, you can name it, multiple sclerosis, what have you, they're always more in women compared to men. So then people have done extensive amount of research to try and understand all these things. And so they are certainly hormonally related. And and then people have looked at genetic reasons for it, as the X and Y chromosome, and look at all this kind of thing. So there's a huge amount of work that's been done on it. But it's true, all these diseases are more in women compared to men.
Yeah. This is an interesting one. What impact does delay in diagnosis of neurologic complications have on neurologic sequelae outcomes in long COVID? I don't know if it's too early for us to even know, but would a delayed diagnosis?
I think the one thing that I've seen, at least with brain injury, is that many patients feel like a lot of people tell them this is all in their head, or they're imagining it, or it's not real. And once they have an objective measure of dysfunction, they feel relief, and that relieves some of their anxiety because they have a diagnosis. So that I would say is helpful, is they feel sort of validated by having an objective measure that tells them something's really wrong. That is one clear, something that can happen, early rather than late. I don't know about other, maybe Dr. Perlowski or Dr. Nath can answer.
I think you're absolutely right. The thing is that unless you have a disease-modifying therapy, biologically, it doesn't make that much of a difference. But psychologically, it makes a huge difference to know what you.
And also a lot of questions about PCPs and other physicians out there not being knowledgeable or aware of long COVID, and how we can, in general, raise that awareness level with them. I don't know if there are any thoughts on that.
And that's the job of the public health service, really. And there's a lot in the media everywhere, so people don't read it. How you can get it through their head, but it's a new disease. It takes a while.
Yeah, and there's a question here about the rehabilitation methods for concussions and TBIs. Have they been used in long haulers with measurable success? I will just say that we're looking for research partners to work on that. And so if anybody on the call is, doing research in that area, we're very interested in potentially partnering up so that we can make some real progress forward that's documented, that's scientific, peer-reviewed, all of that. And there was also a question about vaccines and vaccinations. Dr. Nath, you mentioned in just one or two slides that vaccinations, can result in some of these side effects. Could you just talk a little bit more about that?
Yeah, so some of the long COVID symptoms that we're seeing can actually be people who had vaccines are also reporting similar kinds of symptoms. And so that suggests to us that maybe the spike protein, immune response to the spike protein is the case. If that really is the case, then it tells you what you really need to do is block those immune responses. So I think in a way that's actually quite helpful for us to know. But the thing is that if you have side effects from the vaccine, the only way you can get it is that either the spike protein is directly causing damage or it's an immune response. The amount of spike protein produced is so little, and it gets into the draining lymph nodes. That's about where it goes. So that cannot really cause the symptom. The symptoms have to be the immune response to it. So an immune response to it, then all you have to do is treat patients with immunotherapy, and you should be able to make a difference.
One of these folks has said that, just to clarify, psychiatric disorders do not mean that they are imaginary or just mind problems. Beyond that, there is also a reactive depression and anxiety related to having COVID, not specifically caused by COVID. So I think you should be highlighting these issues as well. The other key point derived from this talk is that COVID is not a brain injury disorder akin to trauma. It is an inflammatory and hematological disorder which can cause brain problems. And so we need to clarify that Dr. Nath is not agreeing that this is COVID is brain injury concept advanced by Dr. Samadani, at least in large numbers. They would look at the brainstem with certain MRI and evoked potential studies for the cardiologist who has had breathing and hypoxia difficulties. And this is from a neurologist that's listening to us, Dr. Kenneth Gross. So that's an interesting additional perspective. I don't know if you guys want to comment on that.
Well, I don't think I would say that, long COVID is similar to brain injury in terms of pathophysiology, but I would say that it's similar in terms of manifestation. And so there are some, like microhemorrhage can happen with brain injury, and it does happen. And, obviously that happens with long COVID as well. Dr. Nath, do you want to address any of that?
Well, I agree with you. I mean, there are different diseases, but there's going to be overlap in the symptoms and some of the pathophysiological mechanisms. And with injury, you can get long-term inflammation too. So that's quite possible. The other thing about psychiatric, I think people confuse psychiatry, psychology, and neurology the thing is, it's all man-made terms. They mean absolutely nothing. There's just one brain, and that's it. You have schizophrenia, it's a organic disorder. I mean, the degeneration of the brain. But just because psychiatrists treat it doesn't mean that it's become psychological and there's not something underlying that's terrible and organic and destroying the brain. And so same thing with depression. I mean, major depression, people actually show there's inflammation associated with major depression. These are ongoing disorders. And if you've done a great disservice by splitting psychiatry and neurology, it's a big mistake. They should be just combined together as a single specialty. There's only one brain. You don't need multiple divisions out of it.
I think fundamental to all of these disorders is a disruption in conduction of signal. And, either whether it's too much signal in some places or too little signal in other places, or, synaptic conduction or electrical conduction, when you have a brain injury, you're going to have a disruption, whether it's due to anoxia, whether it's due to microhemorrhage, whether it's due to the lack of glial support or demyelination. All of these things manifest ultimately as a disruption of function. And so that's what they have in common. And even the so-called psychiatric disorders also fall into that category. So I don't think that they are that disparate in terms of underlying mechanism.
I want to thank all of you, all three of our panelists, but also our audience, which has just been phenomenally engaged. We clearly have a long way to go in this arena. There's a lot of awareness that needs to be raised, even amongst our physicians out there. We need to be doing more talks like this. And this was just a wonderful and healthy debate and discussion. And, we welcome, multiple points of view. We want to hear that. That's what's going to push us all forward in a direction that's going to help everybody. So thank you so much again. We will be offering the recording of this, and we'll be in touch with folks regarding regarding some of the questions that we didn't get to. Thanks everybody. Take care.
Thank you.
Thank you.
Thank you.